Hello, my name is Patricia Terhar. I am a student at Eastern Michigan University and I am in the dietetics program there. And today, what I'm going to be presenting is the case study that I completed this semester. It's my final clinical semester, so this is my final case study. So it's kind of like my capstone project for my time in the dietetics program. So what I'm going to be talking about and what the patient that I did my case study on had was polymyositis and Sjögren's syndrome with malnutrition. So what we're going to be focusing on, the objectives of today, are we're going to be explaining the disease background, going into the patient's history and disease state, reporting my nutrition diagnosis, laying out the nutrition intervention, and outlining the nutrition monitoring and evaluation for this patient. So we're starting off with polymyositis and the epidemiology. So polymyositis, or as I'll sometimes refer to it as PM, is an idiopathic inflammatory myopathy, or IMM, that presents with symmetrical weakness and chronic inflammation of skeletal muscle. Now, polymyositis is often referred to in tandem with dermatomyositis, which is also an idiopathic inflammatory myopathy, which just has like a rash or a skin rash associated with it. So they're kind of similar, but they're also different, but they're referred to together usually. Its PM is most common in women and African Americans. It's most common to occur within the age of like 31 to 60 years old. It has an incidence of 4.27 to 7.89 per 100,000 people and a prevalence of 9.54 to 32.74 per 100,000 people. Now, usually PM is pretty overdiagnosed. It can be confused with connective tissue disease or like a muscular dystrophy, malacia, toxic or endocrine myopathies. It is actually an extremely rare disease. And along with the rarity of this disease, there is like an increased amount of medical costs per year. It's around like 15,000. Next, so we have the pathophysiology. So what most of the literature states is that it's very similar to an autoimmune disease, but they don't necessarily quite equate it to an autoimmune disease, where it's the T cells, the dendritic cells, macrophages, they're in the myofiber, and they induce the myofiber necrosis. So they're basically attacking the muscle cells. It is also part of it as well is a chronic antigen-driven humoral immune response, which is B cell driven, which is part of the B cell humoral response in general. And it also can be due to hypoxia, just the lack of oxygen in the cells, which leads to like a lot of genetic, it allows more genetic processes to occur when that happens. So in general, PM, it invades and destroys the muscle fibers through T cells, very similar to an autoimmune disease process. Now, the etiology of polymyositis is largely unknown. People sometimes, there's lots of theories on how it happens and how it occurs, such as if it's a viral disease, an infection, or if it's just genetics. The clinical manifestations of PM are proximal muscle weakness, difficulty with fine motor movements, muscle pain and tenderness, the weakness of the neck. There's difficulty swallowing, fatigue, shortness of breath, fever, weight loss, and irregular heart rhythms. Now, what it starts with is a weakness of the central muscles, more so in the central part of the body, the proximal, and then it goes more towards like the distal weakness. So which is why like the weakness of like the neck and the difficulty swallowing will show before the weakness of like picking things up and stuff like that. The other clinical manifestations are like in the blood, like what you get from blood tests. So there's an increase of muscle enzymes such as creatine kinase, lactate dehydrogenase, aspartate aminotransferase, and alanine aminotransferase. There's also an increase of levels of serum aldolase and myoglobin, and an increase in serum antibodies of anti-Jo1 and anti-aminoacyl tRNA, which are all indicators of what is going on and like help with the diagnosis of PM. The treatment for PM, it includes a lot of different things. It includes immunosuppression, physical therapy, prevention of complications, resistance exercises, and strength training programs. So the first line of treatment is systemic glucocorticoids. They're usually used for remission induction for about like 2 to 4 weeks. The main one used is prednisone. And then the second line of treatment includes methotrexate, azathioprine, tacrolimus, and a lot of other immunosuppressive medications that like will help suppress what is going on. Physical therapy is also a big part of it. It doesn't stop it from happening, but it can help mitigate the results. Prevention of complications, resistance exercise, very similar to physical therapy. And then there's a strength training program. There's a 9-week strength training program that's been shown to have significant improvements in muscle strength and function without adverse effects for those with chronic PM. And resistance exercises are also safe for patients with PM at 1 to 3 months into treatment. While muscle enzymes do remain unchanged, like I said before, the exercise help improve aerobic capacity and muscle strength in a safe way for patients with polymyositis. Now, part of the nutrition interventions, similar to how people tie gluten intolerance with a lot of autoimmune diseases, in that sometimes when there's an autoimmune disease, it also can cause gluten intolerance. Part of what can help is like doing a gluten-free diet for these patients. There's also vitamin D supplementation should be considered, because with the loss of muscle, and also it's usually tied to an arthritis or an osteoporosis. So the vitamin D can help with bone health, with the lack of strength provided by the muscles around. And then there's also the nutrition intervention surrounding like swallowing difficulties and dysphagia, and working with the patient on different textures and different food preferences. For prognosis, there's a 50% survival rate for 5 years, and then a 10-year survival rate of 62%. Many deaths of polymyositis are related to cardiac and pulmonary complications, infections, and cancers. 80% of patients will have a chronic continuous disease requiring continuous immunosuppressive treatment, which has a lot of implications on terms of what those potential like nutrient deficiencies that those treatments can cause in a patient. Age is an important predictor as well. Patients older than 64 years have a mortality rate of 47.8% compared to a 9.1% for younger patients. Many patients with PM experience limitations in being able to do activities that require muscle endurance, like walking, biking, climbing stairs, and jogging. And there's limited room for improvement with physical therapy interventions, which means that these patients will never be able to gain their full strength back. So while physical therapy is really key in treatment and in preventing further necrosis of like the muscle or decay of the muscle, even then what is lost can't really be gained back, which leads to a limited quality of life for these patients, which leads to a worse prognosis. Now moving on to Sjögren's syndrome. So Sjögren's syndrome was originally described by a Swedish ophthalmologist named Henrik Sjögren in 1933. So what stood out to him was that it was the dry eyes and the mouth, but it wasn't related to a vitamin A deficiency or xerophthalmia. What he found is that typically it was the dry eyes, dry mouth, and arthritis. And now there's other diseases that are linked to it as well as arthritis, such as polymyositis. It is an autoimmune disease characterized by xerostomia, keratoconjunctivitis, Zika, which are often associated with lupus, rheumatoid arthritis, scleroderma, or polymyositis. It is the second most common chronic autoimmune rheumatic disease, and it has a prevalence of 9-to-1 to 13-to-1, with a prevalence of 0.2% in communities and 0.04 to 0.06% in hospitals. In the US, there was counted to be around 0.4 to 3.1 million cases in 2008. And overall, there are only 200 cases of childhood Sjögren's syndrome noted. It happens a lot more in women than men as well, too. So the pathophysiology, it is an autoimmune disease, so it's immune-mediated destruction of the salivary and lacrimal, or the tear duct glands. The autoantibodies that are part of the pathophysiology are an anti-SSA/Rho or anti-SSB/LA, a rheumatoid factor, cryoglobulins, and anti-nuclear antibodies. So similar to polymyositis, it's the T cells, the B cells, the macrophages, the dendritic cells, and epithelial cells. And it's a chronic inflammatory response. It also has a development of adipose tissue and fibrosis in salivary glands, and it can be a primary disease or a secondary disease. So primary means that it is occurring all on its own, and then secondary is it's usually occurring because of something else, such as rheumatoid arthritis or polymyositis. So in Sjögren's syndrome, the etiology, very similar to polymyositis, because it is an autoimmune disease, it is largely unknown. There's theories about genetics and how it can be increased. There can be an increased risk for first-degree relatives. There's theories tied to the Epstein-Barr virus, and then there's also theories about environmental causes of autoimmune diseases. The clinical manifestations of Sjögren's syndrome, there's a lot of them. What we already talked about, like there's the dry mouth, the difficulty speaking, chewing, and swallowing, reduced quality of life. There's increased risk of dental caries because of the lack of saliva that occurs in the mouth. So the stuff just stays in the mouth. Cheilitis, inflammatory joint and muscles, pain, chronic fatigue, swollen salivary glands. There's neuropathies, fevers, constipation, Zika of other organs that are saliva or mucus producing, acid reflux, dysphagia, dyspepsia, and bacterial overgrowth. Other clinical manifestations are decreased concentrations of IgA, lactoferrin, salivary proteins and peptides in the blood. Kidney, it's usually associated with kidney stone formation, and hyposalivation, which is less than 0.1 milliliters of saliva per minute. So one of the article reviews that I have for this patient, or that I had in like doing all my research, was done on sleep quality in patients with primary Sjögren's syndrome. So it used the Pittsburgh Sleep Quality Index, and it evaluated 31 female outpatients at the Sapienza University of Rome and compared them to healthy controls. And so what they found is that there was significantly higher Pittsburgh Sleep Quality Index scores in patients with primary Sjögren's syndrome, and a decrease of global sleep quality. So what they tried to do is they tried to tie what was causing this decrease in sleep quality. So they talked about pain, so how we just talked about the clinical manifestations with like the inflammatory joint pain and the difficulty swallowing. They conflated that with it. They saw that as a reason. Another reason that they tied to it was that, like, because it's so dry for the patient, they need water throughout the night in order to be able to like swallow and to just sleep without like having trouble breathing. And then they also related it to, because there is an increase for anxiety and depression in patients with Sjögren's syndrome, they related the poor sleep quality to anxiety and mood disorders as well. In terms of treatment for Sjögren's syndrome, there's medication for salivary hypofunction, so sialogogues, the pilocarpine, and the cevimeline. There's salivary substitutes that they can use, such as chewing gum or sugar-free lozenges that they can, they're usually sugar-free to prevent dental caries for patients, and that can be used to help try and induce or produce more saliva. For eyes, there's artificial tears, and they also can use like warm compresses, lid scrubs, topical antibiotic drops for blepharitis, and it can get so bad in terms of eye dryness that they may need eyelid surgery in some cases as well. Other forms of treatment, there are no disease-modifying drugs that effectively treat Sjögren's syndrome. Totally, there's certain drugs that focus on different clinical manifestations, such as hydroxychloroquine, which helps with symptoms and clinical manifestations. A second line of therapy is methotrexate. Prednisone can also be used in short term. There's steroid-sparing agents that can be used, and usually rituximab is a last resort. It's a biological treatment for patients with serious organ manifestation, because in Sjögren's syndrome, it's not just usually the salivary and lacrimal glands. It can have severe impacts on the kidney, the lungs, and the nervous system as well too. In terms of other treatments, aerobic exercise is the only strongly recommended treatment for fatigue in patients with Sjögren's syndrome, and also there is no evidence for electrostimulation or acupuncture for patients with Sjögren's syndrome to help try and induce salivary production. In terms of nutrition interventions, fluoride treatments to help with dental caries, to help prevent them, and to help maintain oral health is something that is definitely part of the treatment process. Omega-3 essential fatty acid supplements can be used for dry eyes. Also, Sjögren's syndrome is usually associated with a decrease in certain nutrients like iron, vitamin B12, folic acid, vitamin D, and coenzyme Q. and those can be used as additional supplements. And then there's artificial saliva paired with fluid, and you want to make sure that the patient is getting the correct type of fluid, like focusing on more so drinks that don't have caffeine in them, like nut pops and stuff like that, more so just like water and other things that help keep the patient from becoming constipated, or avoiding like diuretics. And some patients may even go on a liquid diet, and so there's special consideration for that in terms of making sure that they're getting all of the macronutrients and micronutrients that they need through that liquid diet. Which also you would want to talk to the patient about, like diet textures and what works best for them, maybe even trying to put them on like a puree diet versus a liquid diet. The second article that I looked at while I was researching was talking about undernutrition and sarcopenic obesity, if they're under-recognized conditions in patients with Sjögren's syndrome. So they just did a basic overview of Sjögren's syndrome and malnutrition and sarcopenic obesity. And what they found was that there's reduced physical activity in patients with Sjögren's syndrome, which they kind of saw as like a cyclical point for fatigue and loss of muscle mass. So each informs the other. So like Sjögren's syndrome leads to fatigue, which leads to loss of muscle mass, which also in turn goes back the other way as well too. What they also found is that there's a fair amount of patients with Sjögren's syndrome who use an unhealthy diet and have a higher energy intake. There's a large lack of studies on dietary intake and nutritional status of patients with Sjögren's syndrome, which is what makes looking at undernutrition and sarcopenic obesity in these patients interesting, because even if there is that higher energy intake, it could be more so liquid focused or more so items that help them produce more saliva rather than energy dense food items. There are many nutrient deficiencies associated with Sjögren's syndrome, such as energy deficiency, protein deficiency, vitamin A, C, B1, B2, B6, fiber, iron, calcium, and zinc. The prognosis for Sjögren's syndrome, what it is typically tied to is an increase of risk for B-cell lymphomas. It can affect the lungs, kidney, and nervous system. A lot of people have not taken Sjögren's syndrome as seriously because they just view it as something that is affecting the salivary and the lacrimal glands, which, can be seen of more as like an inconvenience than a risk to the patient's health. But more recently, they found that because of the way it attacks the glands, it can affect the lungs, kidney, and nervous system in a way that can lead to worse prognosis than was prior anticipated. There's weight loss, and GI and digestive issues can lead to a worse prognosis for patients. There's high rates of depression and anxiety, and usually the prognosis is worse for secondary Sjögren's syndrome. And as we talked about before in the clinical manifestations, there's a decreased quality of life for patients with Sjögren's syndrome. Prevention, I lumped together polymyositis and Sjögren's syndrome when talking about prevention because they are very similar in etiology, in that, we don't know exactly what it is that causes them. We have theories on like genetics and viruses and environmental impacts, but it's still very largely unknown. So just general recommendations for health are used in terms of prevention for these diseases. And even with like genetics, it's not like there's much that can be done other than avoiding stressors or avoiding other than avoiding stressors that could environmentally increase risk of developing the disease. The third article that I found that I thought was really interesting while I was researching Sjögren's syndrome was an increased risk of thyroid disease in patients with Sjögren's syndrome, a systematic review and meta-analysis. So the aim of this study was to evaluate the risk of thyroid disease in patients with Sjögren's syndrome. And what they found was that the risk for thyroid disease is increased in patients with Sjögren's syndrome, and so is the risk for autoimmune thyroid disease as well. And what they found is that Sjögren's syndrome and thyroid disease share the same level of pathogenic basis at the gene level. And the risk and prevalence for both of these diseases increases with age. So they kind of, as age grows up, the prevalence for both of them increases as well too, which is something that they took into consideration in their data analysis. But I just thought it was very interesting as well too, because they noted that the salivary and the thyroid gland are very similar, and the autoimmune process and the pathophysiology of these diseases is very similar, and how they tie together. And now we're going to go on to the resident's history. So I'm going to refer to the resident as DS for HIPAA reasons. And what we're going to do is we're going to go over their social, medical, and nutrition history. So first of all, DS, before this incident, she lived at home with her husband. She has 3 daughters, one of whom she told me was getting married soon. She was a lunch lady. She likes knitting, crafting, playing Scrabble, Yahtzee, and watching the Food Network. She also very clearly had a wide social network. The multiple times I went in to go and assess her, she had all of these cards and lots of flowers and decorations in her room that were from family members and friends sent to her to help her get well. So she has a pretty big social support. So in terms of medical history, in this specific incident, she was admitted to the hospital on January 25th after a fall, which caused a fracture of her right femur and a subsequent surgery on January 26th. On January 28th, she was admitted to Wellbridge for skilled care. And then on February 22nd, she was discharged to an assisted living facility to continue her therapy before she went back home with her husband. Her medical history includes polymyositis with myopathy, diagnosed in 2018, Sjögren's syndrome, Barrett's esophagus, osteoporosis, hypothyroidism, GERD, iron deficiency anemia, thyroid cancer, diverticulosis, malaise. She also has a history of different medical procedures, such as the gastroscopy, colonoscopy, appendectomy, muscle biopsy, lipo-excision, hysterectomy, and thyroidectomy related to the hypothyroidism and the thyroid cancer she had before. In terms of her nutrition history, she reported a decreased intake over the past year, which correlated with a loss of 30 pounds, which is a 19.2% loss in body weight. She also reported the use of Ensure and meal replacements before going to the hospital or coming here. She states difficulty chewing and swallowing due to Sjögren's syndrome, which she states is like she doesn't usually like to eat like chicken or meats because it requires a lot of energy for her to cut it up in the first place and then to chew it, to make it so she can be able to swallow as well. She already has a bridge and tooth implants in her mouth, so she doesn't really have her own teeth. And she's reported that she has had like a decreased appetite. And in that, like, she doesn't necessarily feel like she has the same hunger cues as she used to before. So she stated that, like, it made her harder for her to eat because when she was at home, it wasn't like someone was bringing her a tray and being like, it's time for breakfast, lunch, or dinner. It was more so just a being at home, not feeling the need to eat, so she just wouldn't eat. This is a list of all of her medications. I'm going to go over some more specifically. So she's on levothyroxine for hypothyroidism, which has a interaction with calcium and iron. Those both cause a decrease in absorption. It can cause a decrease in absorption of calcium and iron. Cevimeline for Sjögren's syndrome, which was mentioned before as part of like the treatment for increasing saliva, has many adverse nutrition reactions such as like constipation or nausea, vomiting. Omeprazole for GERD can, if used long term, can lead to a deficiency of vitamin B12. Ferrous sulfate for iron deficiency anemia. Eating calcium while taking this supplement can cause the iron to be not absorbed. And looking then towards the calcium supplement, there's the interaction with iron where calcium causes iron to not be as absorbed as much. So we have to make sure that those medications are taken at separate times so they don't interfere with each other and each other's absorption too much, along with the levothyroxine. This is a table of her lab values, and I'm going to go over some specific ones that were out of range. So her hemoglobin and hematocrit were very low, which can be tied to an iron deficiency anemia. It can also be tied to a lymphoma, and it's the reason why she's getting the ferrous sulfate right now. But it also could be the iron deficiency could be coming from, again, an interaction with the levothyroxine and the calcium supplement that she's taking as well, which could not be separated and could be taken at the same time and are interfering with the absorption of each other. The platelet count, she is on heparin, and so that makes sense with why the platelet count is decreased. And also heparin is part of what could be causing the thrombocytopenia as well too, which is indicated by the platelet count. It also could be a sign of lymphoma, and the platelet count is also a sign of low vitamin B12, which could be due to the omeprazole. And then with prothrombin with time and INR, it could be linked with liver disease and vitamin K deficiency. And so the liver disease, as we talked before, it could be part of Sjögren's syndrome and polymyositis affecting other organs in the body. For her nutrition-focused physical exam, what I found was that she had that loss of 30 pounds in the last year. That's what she reported, which is the 19.2%, which is just under the 20% in under a year in terms of malnutrition. She had a Braden score of 15. She did have surgical wounds that were not a concern on her right leg due to the surgery that had to be done because of her fractured femur. There was no edema present, but there was severe subcutaneous fat loss and muscle wasting noted in like the orbital, the gastrocnemius, and regions. She also had a brace on due to the fracture and the surgery to keep her legs straight, which also should be taken into consideration of like her weight. So like once it comes off, she could have a slight drop in her weight, which could be due to the brace that she was wearing. She also had self-reported loss of hand grip strength. So we didn't have the hand grip strength tool at the facility to use for her. But something that she did state was that she was having trouble using the tumbler that we had that was about like this big, a normal sized tumbler, probably like 16 ounces. She was having trouble using that tumbler with both of her hands. And so what she requested was that we send her drinks in the smaller glass 8-ounce cups so that she would be able to use them. But it was something that I used to be like, she had to use both hands for the tumbler, and even using both hands for the tumbler, she didn't feel safe being able to drink from it and not spilling it on herself. So I saw that as a reduce in hand grip strength, even without using a tool. For the nutrition diagnosis, I had 3 PES statements. So the first one was swallowing difficulty related to Sjögren's syndrome, as evidenced by prolonged chewing and feeding time, decreased food intake, avoidance of harder foods, need to drink water in order to swallow foods, as reported by patient. And then underweight related to Sjögren's syndrome as evidenced by a BMI of 16.9 for an older adult, observed muscle wasting and loss of subcutaneous fat, and an estimated intake less than measured needs, which excludes items that tend to be higher in protein related to difficulty in chewing and preference, talking about how she didn't like eating meats because they took so much time. And then she also reported that she didn't really like cottage cheese or yogurt, which are really good, more liquid and easier to swallow sources of protein for her. And then severe chronic disease related malnutrition related to polymyositis with Sjögren's syndrome as evidenced by a BMI of 16.9, a 19.2% weight loss over 1 year, severe loss of subcutaneous fat around the orbital region, severe loss of muscle around the temporal, clavicle, quadricep, and gastrocnemius regions. A patient reported reduced strength due to the not being able to hold the tumbler with one or both hands, and a history of meal replacements and reduced intake per patient history. So the nutrition intervention for her focused on giving her Ensure 2 times a day and making sure to give it to her in between meals. What we did first and foremost is we updated her tray card preferences. So we went in to talk to her, and we spent a lot of time talking to her about preferences in terms of what she likes to eat, what was easy for her to eat, what drinks she liked, and like how she wanted her to get her drinks. So we have like an extensive list of all of her likes and dislikes, and we made sure to include things on her tray ticket that she would be able to eat, like including extra gravy or extra sauces with certain meals, extra syrup, on her pancakes and with her eggs. Part of the nutrition intervention as well too was doing weekly weights, encouraging physical therapy. Something as well too that I thought would be a good nutrition intervention for her would be recommending an appetite stimulant, because she reported not feeling like she had an appetite. So that is something that I would discuss with the interprofessional team to see as a potential intervention if it's something that would be needed if she continued to not eat. Educating the patient on her interactions of medications and supplements, so when she leaves, she is able to make sure that she's taking them in an order and at a time where they don't interact with each other. And then education on fluid consumption and oral hygiene. For fluid consumption, talking about like avoiding caffeinated drinks, and then oral hygiene is just maintaining and making sure that even though you want to encourage her to eat as much as possible, also making sure that there isn't just food staying in the mouth and creating further problems, further dental caries for her teeth. So the monitoring and evaluation focused on weekly weights, intake, monitoring her intake, and focusing on malnutrition and seeing improvement in those areas, and watching her lab values, her hemoglobin, prothrombin time, INR, and platelet count. What we saw during DS's stay was a weight increase of about 1 to 2 pounds. When we went to go talk to her, she said that originally her goal was to maintain her weight at where it was. And when we told her, and she knew about her weight gain, it was something where she was like, I guess it won't hurt. And it is something as well too, because of her BMI, we wanted to increase her weight and encourage her intake. Something else that we noticed is her acceptance of protein supplements. What was happening is she was focusing more on eating the food, which is good, which is what we wanted. We wanted her to eat oral nutrition before doing the protein supplements. And she said that she would take about 1 Ensure a day, usually more so during the night. So she was accepting 1 out of the 2 Ensures, but she also had an increase of being around like 25 to 50% or 26 to 50% of intake to closer to 51 to 75% of intake of most of her meals, which included a lot of additional items on her tray to help her increase her intake. Something else we also did is we did a follow-up with progress note to get updated dietary preferences during her stay, to continue to increase that intake and to make sure that she was getting stuff that she wanted to eat and that would help her continue to gain weight. So in conclusion, for polymyositis and Sjögren's syndrome, the one that really drew me into this patient was the Sjögren's syndrome, because it does make it so hard for the patient, and there's so many other considerations to think about in terms of what it means to not have saliva, and to have drier eyes and other stuff like that, and how much it doesn't just impact intake in terms of what you can intake, it also impacts your teeth, which also in turn impacts your intake. And then the polymyositis was also really interesting in terms of when I first went in to go see her, I didn't fully know what polymyositis was, and I was kind of taken aback at how little muscle she had. And it probably is something that has worsened due to her loss of 30 pounds in the last year. But it was something that, because it is also such a rare disease as well too. It was really interesting to see the implications of that. And while it was later on in her disease process, so it wasn't necessarily something where physical therapy could, maintain her muscle mass at where it was, it's still something that, encouraging the physical therapy could continue to still help her have somewhat of an increased quality of life. The recent research, I especially thought that the sleep one was really interesting, considering that the fact that it might just be that they need to continually get up to drink water while they're sleeping, because it's something, and the pain that they have is something that was really interesting. And then the correlation between thyroid disease and Sjögren's syndrome was also really interesting, because the patient had hypothyroidism and had a history of thyroid cancer and a thyroidectomy. So that correlation was really interesting to me as well too. DS was a very pleasant patient. It was the first patient I've been able to do a case study on who I could talk to, because my first semester I did one on a virtual patient, and then my second semester I did one who was a nonverbal patient. So what was really cool about DS is being able to work so in depth with her on her preferences and on what we can get her to eat and how we can help her out with her condition to improve her disease state and to improve her healing of her fracture. So it was really, really interesting to be able to spend so much time with the patient and see the results and see how liberalizing the diet for the patient and working with them individually really did help increase their intake, and the education that we gave her really did help her, want to eat more food rather than just supplements. My thought for the case, I still believe that there's not the greatest prognosis for this patient in terms of how far her diseases have already progressed. She also has a history of falls. This wasn't her first fall, and she wanted to make sure that she wouldn't be a burden to her family, in terms of, wanting to get better, and not leave the facility because she wanted to be able to walk. But it's something where it's like looking at the prognosis for these two diseases, and especially for how long she's had them. She has a lot to look forward to in her very near future, and I think that is something she'll be able to get to. But in terms of long term, I was concerned about, when she leaves and when she doesn't get the meals at a specific time every single day, and she still doesn't have that same appetite, will she still continue to eat to maintain her body weight? These are my references. And then if you have any questions, please ask away. Thank you.